So we're looking at introducing a standard five-step approach to set and achieve goals aligned to our organizational priorities. So we're using the acronym GOALS. And you can review this as you get the slide deck. But we're also going to give you a leader self-assessment tool to see how you're doing in that area. So that worksheet will be available on Pulse. And also our dear HR colleagues are giving us master classes on goal deployment. And also our transformational health team is going to give us some coaching on continuous improvement. So that'll start on Tuesday, August 12th. And that will be ongoing throughout the year. So in looking at our goals that we achieved from this past fiscal year, we did really great. Our quality, we came in, Chad will talk to it later, but we're looking at through May that we're number 6. So that is an unbelievable achievement and sustained over years. How many years now, Chad?
This will be 7 in a row.
7 in a row amongst the top 10 in the country. It's unbelievable. In terms of service, again, we got maxed. 50% of our units had a greater than 1 point or 80 in our net promoter score. Tremendous. So we're going to benefit from that. And then efficiency, looking at our budget. Lori will talk more about that. We still don't have our end results there, so we'll see how we do. And then in access, we met targets, so that's great. Now, in looking at our goals for this year, as I said, we're going to have each of our key leaders go over these in more detail. But for this year, we're looking at, again, advancing our journey to high reliability, no harm, getting number 8, right?
Yeah.
In terms of the 8th consecutive year. And then again, the same thing, service. We're going to continue with that goal, and Leslie will share some of the things we're going to focus on, and then access. Again, we want to go after improving our access to our patients and going with achieving some of our forecasted budget volumes. And then efficiency, Lori will go into that. Again, looking at the cost per adjusted patient day, which is really critical, particularly with our reductions in force. So with that, we'll go on to the next slide. We just are going to have this in your deck. We share this with you every month, the resources that are available to you in terms of cascading and meeting your goals for the year.
Yeah, and I have the privilege of sharing with you both our fiscal year 25 performance relative to the quality alignment pillar, but also talk a little bit about fiscal year 26 and our goal for the current year that we're in. So starting with last year, it was mentioned already, but we are projecting number 6 out of 119 academic medical centers. And this would be the 7th year in a row. That relative to our target would mean a max performance. And I get asked this question often, like we've had this goal for a number of years. Why do we keep it? And shouldn't we dial it in even further to make it tougher in terms of the goal as we're setting it? And the truth is, every one of those 119 organizations are working on the same domains that we are. And while we set the goal relative to a relative rank, it is harder and harder every year to maintain and sustain that rank, knowing that it is other organizations focused on it and looking to do the same for their patients. I think I get the chance to say this every time I'm with you, but while the goal set on rank, and we do look at rank as our objective measure relative to this alignment pillar, we don't do it for the rank. We do it for our patients. And I know that's why each and every one of us come to work every day is for the patients we get the privilege to serve. This just gets us a barometer reading on how we are doing relative to our journey to high reliability. So really, really exceptional performance for last year. We are one of only 5 organizations of those 119 that have sustained more than 5 years in a row in the top 10. We are the only UC that has been able to do what we've done in terms of the number of years. That would be number 7, and certainly the number of years in a row. The most any other UC has in terms of top 10 performance is 3. So some highlights. How did we get there? How are we able to sustain this great performance? Well, 3 or 4 things that I want to just sort of highlight here. One is our continued focus on our journey to zero harm. We had 12% improvement in our safety score. We call it that because of our desire to always focus on delivering safe care to our patients. But that score is normalized against our volume. So it's per 1,000 patient days. And in that normalization, we had a 12% improvement. Again, tremendous progress in the face of increasing volumes of continuing to reduce harm year over year. Another part of our success is our terrific performance in mortality. This will be the 5th year in a row where we're in the top 10 relative to our observed to expected mortality performance. That's an exhibit of great care, great documentation of the complexity of that care, and our coding colleagues making sure we reflect that fully in the claims we submit so that it is a full reflection of the really exceptional quality of care we're providing. The next, and it was spoken to earlier, and I got to give a lot of credit to Donna Bifus, who's the co-chair of our Transitions of Care Committee, but overseeing and in partnership with all of you, we did realize 7% improvement in our relative readmission rate, putting us now in the top 25 of all academic medical centers in terms of readmission rates. That is tremendous, and that is a huge success for the entire organization, and it is truly the entire organization. It's while admitted, the care we're providing, and then that continuity of care and making sure our patients have a safe landing space after they've been hospitalized. And that's a real nod to our ambulatory partners who are doing all sorts of improvement efforts to get patients in post-discharge and doing that really exceptional care coordination that follows. So what will be our areas of focus for fiscal year 26? We have to stay committed to our journey to zero harm. We still have more than 1 safety event per day in those areas that we measure. And as I think you all have read, CMS just came out with a publication that they've done studies around the claims that have been submitted to CMS. And they see that 1 in 4 patients are harmed in hospital care every year. And so that rate is far too high. We know that our patients expect to come into our care and not be harmed during it. So it's got to be one of our continued focus areas. We're going to continue to look at our just-in-time dashboards, continue the transitions of care, our focus on that great continuity of care for our patients, and all of the work that's happening under the Access to Care Steering Committee. That's flow, throughput, the RP2 efforts, all of that access work that's happening under our ambulatory access framework. And lastly, you're going to hear from Leslie today, so I won't belabor the point, but it's also one of our expectations of our patients is they come in and we treat them nicely, we treat them well, and that gets reflected back to us in that patient experience score. Next slide. So here's a summary of our results, a summary of how do we sustain that success. So I'm not going to read that to you, but I do want to highlight one other aspect that we don't call out in our goal, but know that we all monitor internally, which is from Vizient's perspective, we are also benchmarking our East Campus uniquely. That is our community hospital, and we are striving for the same, to be a top 10 designation amongst the 245 community hospitals in that benchmark cohort. I have to give a great shout out to all of the teams at East Campus delivering that care. You can see our progress from last year and even our progress month to month. Last time I got the chance to report out on our performance, it was 99 out of 245. And you can see with that incremental work that's happening day in and day out, our current performance is at 76 out of the 245. Really, really exceptional progress and exceptional care that's being delivered at East Campus. Next slide. So this is a sort of obligatory slide for me. This is our depiction of our journey to high reliability. We focus on Vizient because it's our most concurrent data, and it also touches on the 6 domains of quality from IOM. Go to the next slide. This just drills in a little bit further, and I provided a link in the lower right-hand corner here to our performance improvement and patient safety plan. That describes all of what you see on the slide, but it also illustrates really what our patients ask. And I've alluded to this already, right? When they come into our care, they say, don't hurt me, help me heal, and be nice to me along the way. And these measures help us assess our progress towards those patient requests. Next slide. And then I just wanted to touch on, our quality public profile. Again, we do this for our patients. All of the work, all of the stuff I've mentioned to you thus far is for our patients. It does pull through in ranks and ratings and how the public and community sees our quality performance. And you can see that illustrated on the left-hand side. And here we've also provided some of those timelines or data time periods that these external agencies use to rate our quality and performance improvement. And you can see in the upper right-hand corner, Vizient is the most concurrent. It's why we focus on it, and it's covering the right domains. So thank you for all you do, for the success we've had, and the success I know we will continue to have on behalf of our patients.
Appreciate that lead in, especially the nod to the patient perception of experience. And so we've got a lot of slides. So we're going to jump in here and really go through. I've got a lot of supporting slides. So high level, we'll look at the outcomes, the new goal, what we learned, and then what we're going to focus on, and then the tools that we've designed to support the leaders on this call. So let's jump right into the next slide. Taking a look, Margarita alluded to this, but this is really the breakdown here of our FY25 organizational goal, which you will remember is 100% of the team member incentive. So we're really glad to share that we met max on that goal. So team members based on eligibility can earn up to the $1,000. I don't have details or a timeline on that yet, and we'll certainly work with HR to communicate that when we know a little bit more information. The next slide really shows and this is kind of a mixed story, right? We met max, but when we peel that back and look at it, we still had areas of opportunity. So many units were making progress. You can see in the green there at the end, 235 units really pulling us towards that goal, but a little concerning that 164 were still declining. So as we think of that, our organizational goal, and then to what Chad was talking about, those public profiles, if you take a look at the next slide, you can see these are the percentile ranks that pull through a number of those public profiles. And so, for example, your HCAHPS is that blue line up at the top that we're always tracking and trending. Green is likelihood to recommend provider, so a lot of those ambulatory services. And then that purple line, likelihood to recommend facility, so outpatient services, radiology, et cetera. And so a number of those public measures are pulling through that blue line, that HCAHPS, that patient perception of the time they spent as an inpatient with us. And so one of the biggest opportunities, if we were to show another slide, which we don't have to get into all the details, but you've heard me talk about this before, that HCAHPS gap between the patients who come into us through the emergency department and then stay with us as an inpatient versus the patients who are direct admit. So planned surgery and then stay with us for the remainder of their inpatient stay, keeping in mind that about 50% of our patients come in through the ED. So that top line really has a variation at times. So for example, in May, we ended at the 93rd percentile for patients who came in as direct admits, But if you came in through the ED, you ranked us in the 66th percentile. So that's a huge opportunity, a lot of efforts, a lot of partnership with leaders on this call to really close that gap. And we'll talk more about that at some future connecting sessions. If we take a look at the next slide, we can see what our goal looks like for fiscal year 26. So trying to take what we learned from the organizational goal last year, having a little concern about those units that were still declining, and then that eye on our public profiles and percentile rankings, we really tried to simplify and create a unified story here. So you'll see that the maintain 80 net promoter score is gone. It's still important, but we want to make it really simple. Stay where you're at for threshold. Target, let's get a little bit better, 0.5 improvement in your net promoter score, or max 1 net promoter score point improvement. So let's not focus and get caught up on that 80th percentile, just get better no matter where you're at. And I think that's a simpler message for leaders as we cascade to our teams. Next slide. We know from the data, though, what our top drivers are. A lot of times we'll ask, like, where do we start when we're working with a particular leader? So listed here on ambulatory, keeping those patients informed of delays, giving enough information. On the inpatient side, you can see here, underneath all of this is really, though, the foundation of the environment that we create. Is it clean? Is it quiet? Have we done everything to create a sort of level experience that patients expect from us? And then if I was to take all of these boxes and just say, what is the theme? It's trust. I know Chad said, be nice to us. And really that translates to communication. Did the patients feel communicated with? And therefore, did they build a sense of trust in the care and everything that we provided? So our focus this year, as you can see, based on these drivers, is developing trust through communication. So we answered your call as leaders to really develop tools to help you talk about the goals and these opportunities with your team. So I know Brianna wants to walk you through some tools really quickly on this, and we can spend more time at a future session. And Brianna, take it away.
Great. We can go ahead and go over to the next slide. All right, so part of our strategy this year was to create a dashboard where really all of those drivers and key information is in a centralized place for our leadership. So right now, this dashboard might seem a little bit overwhelming, so we'll break it down quickly, but I promise we'll have further learning opportunities to really get used to this dashboard. Go ahead, next slide. So over on the left-hand side of our dashboard is for all of us to be able to track our progress as an organization. So that's a snapshot of our CSIP progress, a snapshot of the slide that Leslie showed earlier of our percentile ranking improvement over time, and ultimately with our goal of trying to get closer to the 80th percentile, not only in our inpatient setting, but in our ambulatory settings as well. And then it's always a good idea just to take a look and see, how are we doing as an organization? How many of our units are improving and how many of our units are not quite improving on our organization-wide goal? So this is really meant to be able to look and see how we're doing as at UCSD as a whole. Next slide. The center is really driven through those key drivers that you saw that Leslie showed for both our inpatient and ambulatory areas, so we can track how we're doing not only as an organization, but at the senior leader level and at the unit level as well. So you'll be able to track those key performance metrics on here. So informed of delays, information about health and treatment, after visit communication, and that trust care team provider care team question for our ambulatory areas. And the next slide. And then you'll have a very similar view for the inpatient setting, really mirroring those inpatient domains that are driving that trust metric that Leslie had talked about as well. So all of this data here in the center of the dashboard is being able to filter down to your specific areas in your units. You can also have subscriptions created so that it can be sent to you on a regular cadence as well. Next slide. Over on the right-hand side of that dashboard is where you're going to be able to find those filters and ability to sort and really drill down to your specific units or areas and track those experience scores regularly. And then we also wanted to include just some best practices of what can we do to really drive trust and build trust with our patients. So we have 8 ambulatory tactics, as well as we'll have 8 inpatient tactics that are really meant, again, to drive those key index questions that you saw on the previous slides. So right now they're linked to our toolkits, but we're currently building out some more in-depth how-to guides that really are a checklist of how to implement these best practices into your places and spaces. We think that our goal right now is to really focus each and every day on at least 1 to 2 of them, but I would say each and every one of these tactics brings something to all of those metrics that you saw, and ultimately drive our organization-wide goal to improve that likelihood to recommend score. Next slide. And then in our dashboards, we have some start guides as well. So you'll be able to see all of the different questions across the different service lines and crosswalk what you're seeing on your dashboard with your particular service line areas. We have some definitions and some resources linked on here for you so that you can, know what to look for and know where to start in your dashboard. Next slide. And then we have some more resources coming out, but the news that we want to share today is that ambulatory dashboard view is live today. It's available in Tableau, and that link is will be made available to you. It's also in the Office of Experience Tableau folder. Our inpatient Tableau dashboard is a little bit delayed. It will be available on August 18th. We're just waiting for this fiscal year 25 HCAP scores to finalize before we publish that for you. Those start guides will be just a tab in those Tableaus, so those are available to you now as well. And then we just learned today that we are going to be hosting our first HR masterclass specific to these dashboards on September 10th. So more information to come on that. We also have our Experience Roundtable as a resource to you. So we are available on the first Thursday of every month from 12 to 1 p.m. Our next session is September 4th, where our team will be there to walk through the best practice guides, as well as answer any immediate questions that you might have about the dashboards and accessing your data.
I think now we're turning over to Matt Satry for access.
All right, thanks, Leslie. Thanks, Brianna. All right, my name's Matt Satcher, everyone. I'm Director of Primary Care and also helping with the Access Initiative. I'm going to take a couple of minutes to talk about a reflection on fiscal year 25's access performance, and then Michelle's going to talk about next year's goals. So for fiscal year 25, our goal was really to improve post-discharge access. You heard Chad talk a lot about that. This is really both access and quality. And frankly, experience. It impacts the experience our patients have, the quality of the care, and whether or not they're more likely to readmit. So the good news is currently we're at target. We are waiting for Vizient data, which won't actually tell us our final score until mid-September. But most of our leading indicators are telling us we're doing a good job of improving this year over year. You can see in both primary care and specialty care, our percent target of post-discharge appointments within 7, 14, and 30 days is improving in virtually every domain. A little bit of a slip in 7 days in primary care, largely just because we're trying to also accommodate a lot of new patients right now. But this is helping our system improve our overall post-discharge and unplanned readmissions. And so you can see that number current, we're improving. This one also lags a little bit behind on data, but year to date, we are meeting our goal. And as Chad said, are under by 7%. So a couple of highlights here. Virtually every one of our areas is making progress, taking a lot of initiative to improve this, but just want to call out a couple of our areas, cardiology and GI, where we've seen that percent of timely post-discharge access more than double. That is really, really important. It really helps us in a myriad of our domains, and just a lot of gratitude to them. Next slide, please. As we think about what we learned over this last year, what we have found is so important is that first and foremost, how do we improve that outreach and connection with our patients? And I'm really glad we work closely with our Care Connection sub-team that's been working really hard to refine the approach for post-discharge access outreach, and we're seeing their connection rates continue to go up. So 60, 70, 80% connection rates mean we're able to more effectively help our patients transition their care and get that great post-discharge access. As noted, we've seen our post-discharge access numbers improve, and we're also seeing that number improve, particularly around our most complex patients we're trying to coordinate care. So this is a lot of where we focused, and we've seen a lot of improvements this last year. As we think about our opportunities and what we want to continue to focus on, we have significantly more demand than we have capacity. So prioritizing those patients that really need our access and our care timely is what we want to focus on. We want to refine which of our patients need our care most within those timeframes outlined, 7, 14, and 30 days, so we can care for them. We also want to discern, and really we're continuing to work together on what's the most effective touch point for our patients post-discharge. Sometimes that might be a specialist, sometimes that might be primary care, but we really want to have a refined system to make sure we get them to the right place timely that can ultimately set off a lot of the right things to occur next. So in this next fiscal year, what can we focus on? What we would ask all of you and our team members to continue to do is continue to look at your post-discharge data and really dig into the specifics of it. The just-in-time access dashboard is a great tool, but that will help us inform very specific improvements. My areas of primary care, we know we need more access, but we really need it in certain departments, and we might need it a little bit less in others. And that's the level of detail we would encourage all of you to start to get to, is understand down at that lowest level where we need most access. And the other thing we would just ask everybody to do is, so many people are working on so many improvement initiatives around that, and you can see that pulling through in the readmissions rates. We would just ask everybody try to keep us coordinated. As Margarita talked about, Chad talked about, the Transitions of Care TOC Steering Committee is the governing body. It's the right place. Please just make sure if you're working on anything and you haven't been in touch or in alignment with this group, please do. And Eric Lundine's a great contact to do that. Just to round it out, gratitude to all of you. Things are improving, and that makes a big difference in our patients' lives and the quality of care they get. Thank you all very much. Michelle?
Thanks, Matt. So for the goal for fiscal year 26, we're really going to focus on achieving and or getting better for our procedural volumes across all licensed sites. We finally have the beautiful McGrath Outpatient Pavilion that opened up a couple of weeks ago. And we also have East Campus. Those are the two focus areas of where our greatest growth opportunities are, because we have the spaces. So we have McGrath with several new outpatient ORs, procedural suites. I have operating room capacity, as well as inpatient capacity at East Campus. And we really want to focus on ensuring that we get those units filled, that we do meet our volumes. And so East Campus, we've done a number of things to be successful in this goal. We really did grow our average census. We're budgeted to be to 110 in fiscal year 26, and we're actually at about 103 today. So I think this is a very easy goal for us to achieve if we all work together. Our average census ended up around 89 in recent quarters in fiscal year 25. We've moved over heart failure. So if you think of other populations that could value, happy to work with you as service line leaders to move populations over. We've made a number of strategic investments, including robotics. We now have a Da Vinci robot here at East Campus. So if you have surgeons wanting block time, we have block time and we have a robot. We're expanding our capabilities and capital investment to accommodate neurosurgery, spine surgery, improved infrastructure in our GI lab to continue to do even more GI procedures. We're just on the ends of a new refresh of our 4th floor. So did a nice refresh to those rooms to augment our inpatient capacity and really encourage transfers to East Campus. Please, connect with your faculty partners, your service line executives, but consider using East Campus. We're doing great work here. We've made some great investments and love to bring in the revenue to help pay some of that off. But thanks again, and happy fiscal year 26. I think I turn it over to Lori.
Thank you, Michelle. I'd like to share with you our efficiency alignment. When we look at fiscal 25, we had some kind of mixed bag of results. We had very strong volumes. Our ambulatory visits and our work RVUs exceeded budget, and our inpatient ADC was very, very close to budget.
which really resulted in some very strong revenue. We also had some revenue cycle initiatives that drove our increase in patient cash and drove down our days in AR by about 4 days, which also translates into 4 days more cash on hand, as we've talked about. We did some contract renegotiations in the PHSO and got out of some of our full risk and converted them to partial risk arrangements. And we have more work going on in the current year to improve our managed care contract results. Unfortunately, as we all know, we did not meet all of our expense improvements that were built into the 25 budget. We spent, an entire hour with you last week talking about the improvements that are in the 26 budget and all the tools and resources that you have available to you to be able to manage to these new standards that are built into your budgets. As we know, through May, we were not meeting our margin target for fiscal 25. However, the year is still open. It takes, a lot longer to close the fiscal year. And so I don't have the results for fiscal 25 yet as far as where we ended with our margin. It'll be a couple weeks before we have that. You can read all of these insights to learn, but I think the most important insight here is the second from the bottom, that we need to continue to have strong partnerships between our operational and our financial leaders. We have many, many tools available to you. We're here to, work through performance management with you, and we have, resources available to you. So this to me is the most important, insight from fiscal 25 is let's build even stronger relationships between our operational and our finance partners on a go forward basis. And so when we look to the goals for fiscal 26, we're focusing not on margin this year, but we're focusing more on expenses. So on the medical center side, our goal is around total cost per adjusted patient day. So that takes into consideration both our labor initiatives as well as our non-labor initiatives. On the physician group side, our metric is around staff salaries per work RVU. And this is really aligned with our initiatives to utilize our schedules, use our facilities to, the best possible capacity, drive more volumes through without adding more staff. And then on the PHSO side, we're focused on our administrative expenses. So our administrative expenses are all the expenses of running our managed care operations, and this primarily excludes our claims expense. So once again, all three entities of the health system are aligned on the metrics for fiscal 26 really being based on expense management. Next slide. And as I said, our focus areas are, meeting your budgets, increasing volume, as Michelle was talking about, the beautiful McGrath outpatient pavilion just opened. We have capacity at East Campus. And so we really want to increase volumes, and we want to maximize our revenue generation through many tactics, including accurate charge capture, accurate documentation, et cetera. And then the overall driving, goal for us really is to grow our cash. And we want to grow our cash because we want to invest in you, and we want to invest in our facilities and our technology and be able to serve all the patients in the regions that are looking for our care.